In this video, we'll take a look at the appendicular skeleton and the functions of the bones associated with it. To begin with, recall that the appendicular skeleton includes the girdles. So the pectoral girdle, or the shoulder girdle, is the first we look at, and it's comprised of both the clavicle and the scapula. The clavicle braces the shoulder. It keeps the upper arm elevated, keeps it from falling medially. It is the most commonly fractured bone in the body because people, when they fall, reach their arms out to catch themselves, but that places a lot of strain on this very thin bone, often causing it to break. The scapula then, posteriorly, is going to have its acromion process articulating with the clavicle to form that girdle in itself. The lateral part of the scapula has the glenoid cavity, and that's what forms your shoulder joint by articulating with the humerus. This is going to have a lot of muscles and ligaments that are all around it, and it's not a very stable joint, that glenohumeral joint between the scapula and the shoulder. So we're going to study a lot of accessory structures there that help to stabilize it as a very movable joint. Here your clavicle was really identifiable because it had this flat sternal end and then this kind of a sharp rounded acromial end, and then of course that conoid tubercle that sat at the very base. One of the things that you see about it is that it does curve anteriorly. So if you put your hands on your sternum and you kind of walk your fingers along the clavicle, it curves towards the front and then kind of curves backwards again. This anterior curvature is really important because as it breaks, you want it to fracture towards the front. If it fractures backwards, then it has the potential to lacerate some of those major vessels that we learned about, like your carotid artery. And then, of course, is your scapula, nice smooth subscapular fossa where the subscapularis muscle is going to connect. And the spine right over here, really important for naming muscles of the shoulder, like the supraspinatus muscle sitting in the supraspinous fossa, or the infraspinatus muscle here on the infraspinous fossa, and then that nice glenoid cavity right there for articulation with the humerus. So this is very clearly a right scapula, just like this, because that humerus articulates right through there. Nice overview of the bones that you would see: scapula, the humerus, the ulna and the radius, and then of course the bones of the hand. And this makes up, of course, your upper limb. And you can see just how important that pectoral girdle is going to be at keeping the shoulder upright. If you've ever seen anybody who's broken their clavicle, the shoulder kind of hangs down and forward. They can no longer hold it up elevated. The brachium itself is only made up of the humerus. It has a surgical neck and an anatomical neck. So if you look at it, the surgical neck is just indicating where the bone is most commonly broken, rather than the true neck. You have muscles that are attaching to all those elevated projections, the greater and lesser tubercles, the deltoid tuberosity, which was nice and rough. That's where that deltoid wraps across and attaches to the lateral side. And then, of course, you have depressions like the olecranon fossa, the trochlea, and the cornoid process. That olecranon fossa right there is where the ulna hooks in to create the elbow joint. But the cornoid fossa here and the radial fossa are really important because as you bend your elbow, the radius and the ulna have to have a place to fold into and kind of hook right there into the humerus itself. In the antebrachium, this is where you have the ulna and the radius. You can see the ulna to begin with right over here, right there at the very top, is going to form that humeral ulnar or the elbow joint. And so this olecranon fits again into this olecranon fossa of the humerus. And that trochlear knot traps all the way around the trochlea that you see right here. At the very end then, you see that coronoid fossa on the anterior surface of the humerus. That's where that coronoid process kind of hooks into or slides into as you bend your elbow. The head of the ulna is unique because it's here on the distal side, and it has a styloid process that lines up with the pinky. As you look at the radius has a rounded head, and it fits right into the radial notch here of the ulna. And that's going to form the proximal radio-ulnar joint. So you have the elbow joint between the ulna and the humerus, this proximal radio-ulnar joint then between the radius and the ulna. And the round head here of the radius has the ability to rotate back and forth, and this is going to produce supination and pronation as you rotate your palms up and down. And then, of course, you see what's called the interosseous membrane. This is going to be a fibrous tissue here that grips, basically pulling the radius towards the ulna and stabilizing the two of them since they're such thin bones. And then, of course, you move into the hand with the carpals here of the wrist, your metacarpals here of the palm of the hand, and the phalanges running all the way through your digits. Keep in mind, of course, that there are 2 phalanges in the thumb, but 3 phalanges for each finger. As we name them, we of course name them as proximal versus distal, and then we include the middle phalanx here for digits 2 through 5. As we move into the lower limb, you of course see that it begins once again with a girdle. So here's the pelvic girdle, and off of that extends the femur, the tibia, and the fibula with the bones of the ankle and the foot. In looking at the pelvic girdle, you've got 2 os coxae, right? Or os coxa is singular. And this serves a number of functions. First off, like we just saw, you're attaching the lower limbs to the axial skeleton. It's also important because it transmits weight coming from the central vertebral column out laterally, so it spreads it out. But at the same time, it acts like a bowl and supports all the visceral organs of the pelvis. Now, it's a bone that's known as sexually dimorphic. Okay, so there you can tell the difference between the male and the female. And we're going to take a look at that here in just a second. So to begin with here, a couple of unique things about the os coxa. So the os coxa themselves are going to be articulated between one another for the sacrum. So keep in mind the sacrum is considered part of the axial skeleton, but each os coxa forming the pelvic girdle is considered appendicular. Right? You do have the acetabulum as well as the obturator foramen and the pubic symphysis as really interesting landmark structures. So here the pubic symphysis, this is going to be a cartilaginous cartilaginous symphysis joint right through here. Right? And that weakens quite a bit during pregnancy to allow the hips to spread apart and allow labor and delivery to occur. You also have the obturator foramen right there, the hole. And on the lateral side, you would see the acetabulum for the articulation there of the femur. Now, one thing it mentions right here is the obturator foramen is that it's actually not an open space during life. It's closed by a fibrous ligament, and so you don't actually have passage of anything through that space. And of course, you should know that each coxal bone is comprised of 3 separate bones. The ilium is the largest of the 3, followed by the ischium and the pubis. So as you begin to take a look at the sexual dimorphism here with all these pelvic girdles, you see a number of things. So here looking at a male, you can see that the coxal bone itself tends to sit more upright, right? So it's taller, whereas the female is wider from front to back. And what this does is this creates a greater opening in the greater pelvis, right? So it's a little bit wider, even though it's shallow. And then the male is pretty narrow, even though it's deeper top to bottom. You also find right over here evidence of that difference in depth from that sciatic notch. So the greater sciatic notch is really narrow with the male pelvis, but it's really wide with the female as it extends backwards. Now overall, this does create a wider pelvic inlet for the females than the males. And you'll see further evidence here of the widening of the pelvis by looking at what's known as the subpubic angle. That's very narrow and very tall, triangular here with males, but it's more spread out and widened with the females. So make sure you can tell some of the differences there between male and female pelvic girdles. Now, of course, it's important to be able to define terms of the pelvic girdle like this. And so we look at them in terms of how they function during pregnancy. So first off, you have the greater or the false pelvis up at the top with the ilium, and then you have the lesser or the true pelvis down below that. Right? This is named because as a baby is initiating labor and delivery, the baby goes in with the head facing the side of the hips as it's in the greater pelvis. There's a lot more space there. But as it passes through the lesser pelvis, the head has to turn in most cases so that the chin now begins to face backwards. And this doesn't always happen this way. When the baby is turned either face up or the head's turned to the side, sometimes they can accrue some damage as they go through, maybe get some scrapes and some bumps on their heads as they pass through that space. As you begin to look at the femur, you find, of course, that it's the longest and the strongest bone of the body itself. The head of the femur here has the fovea capitis, the site of attachment for a ligament, and this is where it's going to articulate with the acetabulum. It anchors right in there. It's not really a very strong ligament, but it does contain a major artery. You do have some projections, like the greater and the lesser trochanters, the linea aspera, the gluteal tuberosity, and the medial and lateral epicondyles, all of which are excellent points for gripping muscles, right? Whether it's the hamstrings, the gluteus maximus, they're all going to grab onto some of those larger projections that are there. The patella in itself is going to be a bone that actually develops through the patellar tendon. So it's a sesamoid bone. And so you do actually see patellar surface right there on the femur where the patella would sit and kind of glide, and that would be lined with hyaline cartilage, articular cartilage in life. Much as the medial condyles will be smoothed and rounded where they're going to articulate with the tibia below. As you move to the crural region or the lower limb, the tibia is the largest and the only weight-bearing bone of the body. Again, a lot of rough sites for muscle attachment, but the tibial tuberosity that you studied here in lab, that's going to be the site of attachment for that patellar ligament, where the patella reaches that ligament of the patella reaches all the way down from the femur down to the tibia. The fibula itself is not actually weight-bearing. In fact, it doesn't serve a whole lot of process. It helps to kind of distribute muscle attachment, but it often gets removed in whole or in piece to replace missing or damaged bones elsewhere in the body. And so you can see him right over there, good old fibula. And you end, of course, with the feet. The feet have the tarsals of the ankle, the metatarsals for the arch of the foot, and the phalanges. And these phalanges follow the same numeric patterns that those of the digits in the hand did. But what's interesting here about the placement of the feet and the bones and the way they lock together is that in most individuals it creates arches to distribute weight. And so you tend to see that that's maintained by the structure of the bones themselves in part. So the way those bones all kind of curve and lock together, that helps build the arches. Now this is definitely reinforced by ligaments and of course by muscle tendons that need to stay strong and lengthened. Again, damage or overuse, incorrect posture, even pregnancy can cause those ligaments to wear down, and that can cause the arches of the feet to suffer. But as you look at the arch of the foot, you see that they can pass weight very easily back and forth across the front on both the lateral and the medial sides, as well as along this transverse plane here side to side. So this helps you to stay nice and balanced with the spread of the foot, accepting the weight here all the way from the talus and calcaneus all the way out through your toes.